So here we have Marty. Marty's our 16-year-old patient. He's experienced a right ankle inversion sprain about 3 weeks ago. He's not currently experiencing any pain, but there is a lot of stiffness in the ankle. Upon doing a knee to wall test, he achieved 3 centimeters on the right-hand side and 9 centimeters on the left-hand side. Anything below 5 is considered quite restricted dorsiflexion. So the reduced dorsiflexion is going to be a major thing to address here to get the mobility back within the ankle. So what we'll do, we've noticed upon doing a talocrual AP glide, there's also severe restriction there. He's also looking at the subtalar joint. That he found severe restriction on the medial portion of the subtalar joint and mild restriction on the lateral subtalar portion. So what we're going to do here, first of all, is address the lack of dorsiflexion by doing an anterior to posterior glide of the talocrual joint. After that, we'll have a look at the subtalar joint and apply a distraction to the subtalar joint. The idea of the distraction is that it will increase general mobility of the entire joint. So because he has both medial and lateral restrictions, clinically I think it's best to address both of those in the one with the distraction. And then if need be, if he's still got that severe restriction with the medial portion, we could probably look at doing further joint mobilizations to address that further. But for now, we'll just stick to the distraction of the subtalar. With our grades, we're going to do a grade 3 mobilization technique. So basically, the grade 3 and 4, the higher grades tend to have better outcomes for joint mobility, whereas grades 1 and 2 are more used for pain relief, pain reduction for the patient. So we'll use these grade 3 technique. So pushing towards the end of range with a good level of altitude, but not going right to the very end. With our joint anatomy, we'll just cover that first before we go through these techniques. So first we're going to have a look at the talocrual joint. The talocrual joint is a uniaxial hinge joint between the talus and the medial and lateral malleolus. So basically we've got the medial and lateral malleolus, and then we've got the talus here, and that allows us to dorsi and plantarflex. So its open pack position is 30 degrees of plantarflexion and midway between eversion and inversion. Its closed back position is maximum dorsiflexion. With our joint kinematics, so we have the concave surface, the mortise. So again, that medial and lateral malleolus make up the mortise, and then we have the talus sitting there as well. And it's going to slide on the talus in the opposite direction of the ankle, the direction the ankle is moving in. Next, we'll have a look at our subtalar joint. So the subtalar joint is made up of 3 articulations between the talus and calcaneus. It supinates with inversion and pronates with eversion. Its open pack position is the middle of the extremes of range of motion. Its closed back position is in supination. Upon eversion, the calcaneus slides laterally, and the posterior articulating surface slides medially. Upon eversion, the posterior articulating surface slides laterally. Alright, so what we're going to do now is apply these techniques. First of all, just want to make sure we have the right table height, and then checking with our patient. So Marty, I'm going to apply these 2 different joint mobilizations to the ankle to try and increase the mobility issues that you're having. If it may induce the pain that you've been having, so at any point in time, if it is too painful, just let me know. We can stop the treatment.
Okay.
Beautiful.
Thanks.
Okay, so first of all, we're going to do the AP glide to the talocrual joint. So first things first, excuse me. We want to stabilize the upper portion of the leg, holding on to just above sort of the lateral and medial malleolus, stabilizing here. Then we want to use the webbing of our hands, cupping around the foot, around the talus, stabilize, and then we're just putting some anterior to posterior force through the ankle, talus there. So I'm going to start this now, Marty. Just let me know if there's any issues with pain there, okay?
Yep.
So again, I'm using a grade 3, so it's about just pushing towards the end of range that we can get of movement in the joint. I'm going to do about 15 of these. So generally we'll do 3 by 15 and assess at the end of each set. And then our second, we're going to do the subtalar distraction. So this one's a little bit different. What we're going to do here is just cup basically where the talus is with the webbing of the right hand side, and then cup underneath the calcaneus. And we're just going to distract that subtalar. And again, we're looking for the grade 3 there. How's that feeling, Marty? Any pain, anything?
Yeah, that's fine.
Okay, just let me know if there is. Alright, so that's our techniques that we've applied. So hopefully that's going to increase the mobility, both the talocrual and the subtalar joint. Lastly, we just need to write our clinical notes. So first of all, we're going to do 3 by 15, the right hand side of the talocrual joint. And it was an AP glide that we did. We're going to measure our outcomes, increasing dorsiflexion. Next, we did 3 by 15, right, subtalar, distraction, to improve general mobility. All right, now that's with our notes done, and obviously our patient's ankle is completely better. Thanks very much for watching.